Good morning, everybody. At the outset, I would like to thank BOA and MOS for inviting such eminent speakers to this forum and for giving me the opportunity. Our panelists today are a mosaic of experts who, with their pearls of wisdom, will definitely add value to our practice patterns. A very warm welcome to our chairperson, Dr. Meenakshi Swaminathan and Dr. Sumita Agarkar, our convener, Dr. Ramesh K. Kunya, and our co-convener, Dr. Naina Portar. Dr. Naina is an assistant professor from Lokmanya Tilak Municipal College Science Hospital, and she's been trained in AIMS and with Dr. Pradeep Sharma. Lucky to have you here, ma'am. Thank you. And I would also like to welcome Dr. Shirish Thorat, who is a leading ophthalmologist from Akola district of Maharashtra and is also the present secretary of Maharashtra Ophthalmic Society. So over to you, MS ma'am. Can we start?
Okay. Good morning, organizers of this wonderful event, BOA, and all the people on the panel, the speakers. It's wonderful to have you here and to be part of this session. A nice break from all that we are going through right now. So just a general request to audience and to the speakers to keep to time. Request the audience to please type in your questions and and the speakers to keep answering them as the session proceeds. Let's not wait till discussion happens. And I think Dr. Shalini is going to introduce all the speakers. So over to you, Dr. Shalini.
So our first speaker is Dr. Nipa. Nipa, can you just start with your presentation? Dr. Nipa is the head of department Pediatric Ophthalmology and Strabismology, Lotus Eye Hospital. She's also a consultant at the prestigious Bombay Hospital and SRCC Hospital. Having herself undergone rigorous training at SNEC Singapore and Jules Steen Institute, UCLA, Dr. Nipa is a teacher and trainer par excellence. She is a prolific speaker and an avid researcher and an excellent human being, and also has numerous publications to her credit. Dr. Nipa will be talking about some salient features of the ATOM study. Over to you, Nipa.
Thank you, Dr. Shalini, and very good morning to all my friends. I want to thank Dr. Ragini and the BOA for giving me this opportunity. I'm going to talk about the summary of the ATOM study. Can you see my screen, everybody? Can you see it?
Yeah, we are able to see your screen, Nipa. Go ahead.
Okay.
Yeah, muted, madam.
Nipa, madam, please unmute yourself.
Okay, now, sorry for this. So coming back to the ATOM study, ATOM stands for Atropine for treatment of myopia. Now, atropine eye drops for the treatment of myopia progression were tried as early as 1920. Numerous small studies have been done since then. The ATOM study is one of its kinds. It was a double mass, placebo-controlled, parallel group, randomized control trial done and initiated at the Singapore National Eye Center along with the Singapore Eye Research Institute. The purpose of this study was to evaluate the efficacy and safety of topical atropine in slowing the progression of myopia and if it had any effect on the axial length elongation. So this study included 400 subjects between 6 to 12 years of age, myopia from -1 to -6, and astigmatism of 1.5 or less were included in the study. Subjects with normal ocular and general health were included. Children who had undergone any other form of myopia treatment were excluded from the study. These subjects were randomized to one of the two groups. One group got atropine 1% eye drops and the other the placebo drops. But in this study, only one eye was used for the study of each subject in either of the two groups. All children got photochromatic lenses, and the dose was instilling 1 drop daily at night for 2 years. The efficacy of the study was evaluated by studying the change in the refractive error and the axial length. So what did we get? At 2 years, we found that the mean progression of myopia and axial length elongation in the placebo-treated eyes was about a minus 1.2 diopter change and a 0.38 millimeter change, whereas in the atropine-treated eyes, myopia progression was very less, only a minus 0.28 approximately, and the axial length remained unchanged compared to baseline. At the 2-year period, they also found that 2/3 of atropine-treated eyes had progressed less than 0.5 diopter, whereas it was the reverse. Almost 2/3 of placebo-treated eyes had progressed more than 1 diopter. Overall, atropine was well tolerated, and a multifocal ERG at the end of 2 years showed that the eyes were normal. So over a 2-year period, atropine treatment achieved an approximate 77% reduction in the mean progression of myopia compared to the placebo. The study thus concluded that topical atropine was well tolerated and effective in slowing the progression of low and moderate myopia and had an effect on the axial length elongation. Now, what happened to these eyes after 2 years when the atropine was stopped? So the second subset of this study evaluated the effect of myopia progression after the drops were stopped over a period of 1 year. And they found that the mean progression in the atropine-treated group was about minus 1.15 diopter versus a very less rate of progression in the placebo-treated group over 1 year, which means that there was a significant rebound after stopping the atropine drops. Another subset of the study actually evaluated the effect of myopia progression over the full 3-year period, which means 2 years on the drop and 1 year of washout. So a total of 3 years and what happened to these eyes. And they found that the absolute myopia progression after 3 years was significantly lower in the atropine group compared to the placebo group, even though there was a rebound after stopping the atropine drops, but the overall 3-year progression showed that atropine 1% eye drops were still a good option for myopia progression. Coming now to the ATOM-2 studies, the same investigators thought, why not study a lower dose? So they designed the ATOM-2 study with the aim of comparing the safety and efficacy of 3 lower doses of atropine, which means the 0.5%, the 0.1%, and the 0.01%. Again, this was a double-masked, randomized controlled trial, included 400 children between 6 to 12 years of age, included myopia of more than 2. The difference between this subgroup and the group of children included in the ATOM-1 was that these children were slightly older, had more myopia, and this time both eyes were included in the study, which means drops were instilled in both eyes. This study was a 5-year study, had 3 phases. First is the children would receive either of these 3 concentrations as eye drops for a 2-year period. Then there would be a 1-year break, which would be the washout period. And then depending on the number of children who progressed to more than 0.5 diopter a year would then be labeled as progressors, and they would be restarted on one of these concentrations of the eye drops. So let's go one by one. The phase 1 of the ATOM-2 study aimed at studying the efficacy and safety of the lower concentrations, 0.5%, 0.1%, and 0.01% as discussed earlier. What did they find? Mean myopia progression at 2 years in these respective groups was 0.3, 0.38, and 0.49 diopters over 2 years. Please note that this progression is close to or less than 0.5 diopters over 2 years. The mean increase in axial length was 0.27, 0.28, and 0.41 millimeters. So even though these responses were dose related, but the differences in myopia progression and axial length change between these groups was small and hence clinically insignificant. So what did we understand? Consolidating the data from ATOM-1 and ATOM-2, it appeared that 0.01% atropine is clinically similar in efficacy to all the other 3 concentrations, which means 0.1, 0.5, and 1% as compared to the placebo. What about the safety? The parameters studied were pupillary dilation, change in accommodation, and near visual acuity. This study found that accommodation was the least affected in the 0.01% group, so was the pupil size. Near visual acuity remained normal in the 0.01% group. Of course, it was affected to some extent in the higher concentrations. And overall, there were no significant systemic side effects in any of the groups. So what do we have? We have atropine 0.01% has minimal side effects as compared to the higher concentrations in this study, but it is equally effective in treating myopia progression as compared to all higher concentrations, including the 1%. Coming next to the phase 2 of ATOM-2, which means what happened to these children after stopping atropine after 2 years. There was a washout period for 1 year, and the study showed that there was a rapid increase in myopia in children originally treated with the higher concentrations of atropine, whereas the ones receiving the lowest concentration had a minimal change, which means the rebound with the 0.01% was minimal. Again, the second subset of this study re-evaluated the myopia progression at the end of their 3 years, which means 2 years of using either of the drops of the 3 concentrations and 1 year of the washout. So the total of 3 years showed that the myopia progression was least in the 0.01% group. Coming now to the last phase, that is the phase 3 of the ATOM-2 studies. This evaluated children who progressed at a rate of 0.5 diopters or more after the washout period. These children were restarted on atropine 0.01% for the 4th and the 5th year of the study, and the myopia progression was hence recorded. They found that the percentage of children who continued to have progressive myopia after the washout were actually related to the original concentration of atropine, which means 68% progressed in the original 0.5% atropine group versus only 24, which progressed in the 0.1% atropine group. The study found that children requiring retreatment were the ones who got myopia early, had less myopia at baseline, and the ones who increased rapidly in the first 2 or 3 years. What did this study show us? the myopia progression was similar to the progression seen in children who were originally started at the 0.01%. It indicated that this 0.01% was an effective option for retreatment if required. Finally, what did we study or what did we learn from all of these studies? We learned that atropine eye drops reduce myopia progression. We learned that atropine eye drops are safe. Ocular effects are completely reversible on stopping the drops. Atropine 1% is effective to control myopia progression and axial length elongation in the short term, over 2 to 3 years.
I hope you're wrapping up, Dr. Nipa.
Yeah. Lower concentrations can be used. Rebound phenomena occur with higher doses. Atropine 0.01% is almost as effective in reducing myopia progression as the others. It has the added advantage of minimal ocular effects. Atropine 0.01% has the least rebound, and retreatment is as effective as primary treatment. I want to end by saying that overall atropine 0.01% reduces myopia progression by 50% in almost 65% of subjects, and hence that makes it our first choice for myopia progression treatment at this time. Thank you.
Thank you, Dr. Nipa, for having put that so briefly and nicely. Our next speaker for today is Dr. Yasmin Bhagat. Ma'am, could you please share your screen? Dr. Yasmin is an honorary professor of ophthalmology, Grant Medical College and St. George's Hospital, Mumbai. She is an anterior segment specialist with nearly 800 collagen cross-linking procedures to her credit. She was the only Indian to attend the world's first orthokeratology conference in Toronto in 2004 and in Chicago in 2005 when US FDA approved ortho-K lenses. We are honored here to have Dr. Yasmin Bhagat. Ma'am, over to you, please. Ma'am, we can't hear you.
Yes, madam, go to slideshow.
Ma'am, you're not sharing your screen right now?
Yeah, just a moment. Just a moment.
Okay. So any questions for Dr. Nipa till then? Okay, we can take a question till ma'am starts her video. Any inputs? Dr. Nipa, what about the Atom 3 that they are that is still in progress?
The Atom 3 is evaluating the same in younger children. The Atom 1 and 2 targeted 6 to 12-year-olds, and the Atom 3 is evaluating if these can be used in younger children, if it can be used in less myopia in high-risk children, which means where the myopia comes in early and there is a significant family history. I think both these will have the results soon.
Yeah.
Am I audible now?
Yes, ma'am. We can see your screen also. You can start.
Okay. I thank VOA, Dr. Lane, Ragini, and Hema. I'll be talking on orthokeratology to control and reduce myopia progression. Prevention is better than cure. So before the childhood myopia becomes worse, let's treat it. And with the progression of science, technology, and COVID-B, the axial length seems to be increasing more and more. And there is a myopia epidemic whereby 60 to 90% of the teenagers nowadays have become myopic. And Brian Holden's Academy predicts that 5 billion people will be diagnosed with myopia by 2050 and 1 billion at the risk of going blind. That's rather scary. And myopia of -6, why the hell correct myopia? because the incidence of RD, cataract, and glaucoma is higher. Now, the etiology of myopia is mechanical, environmental, and biological. And look at the altered lifestyle of the kids, especially now with online studies. There is TV watching, video games, eyes are constantly used, and there is no playing activity in response to stress. So we have a new terminology like childhood myopia, where kids who have no family history also tend to become myopic. And outdoor activity also reduces myopia. By a study in 1969 with the Inuit people of Alaska, originally only 2 after 131 were myopic, but then with the second and third generation who followed the Western culture, 50% became myopic. And outdoor exposure to light leads to secretion of dopamine, and then that prevents the axial length growth. Now, what are the controls? We have 3: peripheral hyperopic peripheral defocus, ortho-K lenses, and pharmacological, which the previous speaker just told us. Now, what does the ortho-K lenses do? It flattens the central cornea. There is a change in the corneal spherical aberration. Foveal vision is corrected to emetropia. There is retardation of myopia progression, and ortho-K lenses provide support for the peripheral hyperopic defocus therapy. So what are they? It is advanced corneal reshaping. It's a non-surgical procedure, and it utilizes custom designed ortho-K lenses. Custom design is very, very important because exactly the central area of the cornea has to be flattened. So here we have a girl who is 7 years old with minus 2.5 and 3 myopia, but the father is minus 20 and the mother is minus 1.5. What would you say? Okay, let me give atropine, let me wait till the age of 16 and then do LASIK, or would you do something? I treated this girl and her myopia greatly reduced. Very often we have young people coming who have medical exams for a job, and in a day or two they want to be 6x6. What do? LASIK? No. Ortho-K in a day's time with a small number like 1 can get corrected overnight. What exactly happens in ortho-K? You see the cells in the central part of the cornea, the epithelium, it gets shifted to the mid-periphery, and also the stroma gets compressed, as you see in these two slides. And you can see that there's a central depression, which is very similar to what we get in LASIK. Now, here is our ortho-K lens, which has 4 different curves. You have a central curve or a base curve, which is a little flatter than the original. And you have a reverse curve, which is 10 microns steeper, so it forms a tunnel. And as your tears pass, it carries by a push and pull mechanism the epithelium from the center to the mid-periphery. This is what the eye looks like with fluorescent staining. How safe is ortho-K? I think it's pretty safe. There's no damage to the eye like RK, LASIK. Corneal tissue is not cut. There's no poor night vision. And endothelial cell studies show that there's no damage to the endothelial cells. It's for all ages. Now, corneal topography is an absolute must for ortho-K. Now, here you see the 2 photos on the left, which shows pre-ortho-K corneal topography, post-ortho-K. And on the other side, the 2 maps are minus, and you see a beautiful blue deepened center area in the center, which shows this is it. Now, it has to be in the center. If it goes a little up or down, it is like doing an eccentric LASIK. But this is something which is reversible. This shows over a period of 4 years, it's consistent with time. This is a minus 5.5 boy, and the photo on the right is pre and the left is post ortho-K. And you see the corneal profile below the curve, and it shows how on the left there is a beautiful central blue area, and in the mid periphery there is a little peak which can be seen in the corneal profile. This girl was -10, and over a period of 10 to 15 days she became 6966. What's the possible mechanism? Corneal bending, epithelial cell redistribution, compression, decreased cell mitosis, increased cell retention, localized stromal modeling, or multifactorial. We did a little study of 500 myopic children between the ages of 7 to 18, fitted half with ortho-K lenses and the others with glasses. And we measured over a period of 5 years their vision, axial length, and the vitreous chamber depth, and found that there was just half to 1 diopter increase in children, only 30% of children. But progressive myopia, especially during puberty, is greatly arrested by ortho-K. Now, over a period of 5 years, the axial length and the vitreous chamber depth showed that the ortho-K children had just half the amount of growth as the control. So obviously, there was no elongation of eye, was greatly minimized. And in the ortho-K group, more myopic children had less axial growth, while in the controls, the more myopic had more axial growth. So what's the major benefit of ortho-K? In growing children and teenagers, it not only reduces myopia, but retards myopia progression by 2/3, thereby preventing myopic retinal degeneration and other myopic complications in the future.
Yasmin, another 30 seconds, please. Thank you.
Okay. So you use it when the cornea is too thin. And besides myopia, you can also use it for hypermetropia, amblyopia, keratoconus, and it's excellent for certain jobs. So the conclusion is that early detection, trend monitoring of myopia in children, ortho-K lenses will control, reduce myopia progression, expose our children to outdoor activities, go out and play and keep myopia at bay, but don't forget to wear your ortho-K lenses. Thank you.
Thank you. Thank you, Yasmin Madam, for wonderful information. Now, our next speaker is Dr. Prachi Agashe, one of the shining name in the pediatric ophthalmology in the Mumbai. Dr. Prachi is practicing pediatric ophthalmology for more than 10 years in the Mumbai. She had been awarded gold medal at the BOA and SPOSI in 2018 and is doing a lot of work in ROP in Mumbai. Over to you, Prachi Madam, for your talk on myopia and prematurity.
So very good. Dr. Prachi, before you start, there's an audience question. I'm sorry, I had to sign in as an audience and take the questions from there. And then I'm putting it here. So Dr. Nipa, would you quickly answer that question that I've already put in the chat?
Yes, so I would, from the current evidence that we have, I would start at age 6 and I would safely continue till age 14 or 15. I would probably continue it for 2-3 years, take a washout year, and if needed, restart.
Thank you. Over to you, Dr. Prachi. Sorry.
Okay. Thank you, ma'am. So a very good morning to the respected chair and all the eminent faculty members. It's lovely having you all here. Moving straight into my topic, I'll start with the case of this 29-week-old child with a very low birth weight presenting to us with APROP, and the child underwent laser therapy for the same, resulting in good regression of the ROP with no structural sequence. On a regular follow-up at 8 months, the child presents with squinting of eyes. A cycloplegic retinoscopy revealed a very high myopia to the tune of -10 in either eye. Now, as a treating clinician, there are some questions that came to my mind which I thought needed to be answered. So is this refractive error normal for age? What would be the reason for myopia if this refractive error is not normal? Is it the prematurity? Is it the ROP disease? Or is it the treatment, that is the laser that has been done for the ROP? Is there any modifiable factor? Is this refractive error likely to progress? And does this child need to be given glasses? So let us look into a bit of a theory. So this myopia, as the name suggests, is seen in premature babies, seen to develop in early phase of development, which increases till 2 years of age and persists in adolescence. Now, as we know, the premature babies leave the uterus at a time when the ocular structures are still immature. The refractive media is formed in the last embryonic phase or just after birth. Even a lot of retinal development occurs between the 24th week to around 3 to 5 months after delivery. This results in arrest in the ocular growth. Now, as we know, the refractive status of the eye is dependent on a number of these factors. In case of normal emetropization in a normal term infant, the changes that we expect are the flattening of the corneal curvature, the deepening of the anterior chamber, the lens thickness reducing and flattening, and the axial length elongating. However, things work slightly differently in a premature baby. The normal stimulus for the eye to grow is mainly by the peripheral retina. However, this stimulus for the eye to grow is altered in premature babies owing to blurred signals from the periphery, either due to the disease or the laser that is done for the disease. So this results in arrest in the ocular growth and leads to actually halting of the axial elongation of the eyeball, the lens remaining thicker and being anteriorly placed, the cornea remaining steeper, and the anterior chamber remaining shallow. Other proposed theories for this myopia include damage to the rod cells, which are again developing in the peripheral part of the retina, visual deprivation, and light sensitivity. So to answer, is this refractive error normal for age? So from this, we understand that we do expect some amount of myopia in the premature babies. However, things work slightly differently for different factors. If there is only prematurity that is there, the globe would still like to increase and there is still some stimulus for emetropization. However, when there is prematurity coupled with ROP, since there is blurring of the peripheral images, the stimulus for emetropization is lesser. And when there is prematurity coupled with a laser-treated ROP, the stimulus for emetropization is the least. So all of this is a spectrum, including the myopia of prematurity, myopia of spontaneously regressed ROP, and myopia of laser ablation, in which we expect slightly increasing trends of myopia. So in myopia of prematurity, the low birth weight and ROP are implicated to cause myopia, astigmatism, and anisometropia. The risk of myopia at 12 months of age is shown to double with each increasing stage of the disease, with a birth weight of less than 750 grams, contributing to a threefold increase in the risk of developing myopia. So if we have to just look at the refractive error in the ROP cohort, the prevalence of myopia is lesser in patients with subthreshold ROP, which increases to 65 to 70% with severe ROP, and is reported to be almost even at 100% in laser-treated eyes. It's a higher myopia of -4 to -5 diopters, and more the structural sequelae, more are the chances of refractive errors. So if we have a cicatricial ROP, we expect more chances of refractive errors. So I think this kind of clears that the reason for myopia could be any of these or a combination of these. Now, we come across premature babies who have a similar birth history, similar treatment modality. However, the magnitude of myopia tends to be different. One kid may have a myopia of -1 to -2, while the other kids with the same profile of disease and treatment may have a higher myopia of -8 or -10. So what are these factors that are responsible? Is it the birth-related factors? Is it the ocular biometry? Or is it the treatment or the abnormal retinal vasculature? But there is a lot of literature about the ocular growth and the refractive error development post-ROP. I would like to quote this paper from AEH Coimbatore, which has actually given a summary of the studies. So the summary is basically that in these children, the axial length doesn't seem to elongate much as compared to their age-matched normal controls. The corneas tend to remain on the steeper side, while the lens tends to remain thicker. So all in all, their myopia seems to be more of refractive origin than of axial origin. So is there any modifiable factor in all of this? So as we have seen, we know that these are the factors responsible for the myopia. The prematurity, which we can't do anything much about. It could be the effect of the ROP, the disease, but we can't do anything about that. Effect of the laser to treat ROP or combination of the above. So amongst all of these, it is this factor which we can think of modifying. So there is this paper which has talked about the myopia being progressive in patients where a large treatment area has been there. The myopia increasing in number of burns given for the laser and more posterior the disease being there. The alternative to this is, as we know, is the intravitreal therapies that have been used. So there are again a lot of papers that have talked about the refractive outcomes following intravitreal therapies. So a summary of that is that the refractive outcomes of the BEAT ROP trial have shown lesser myopia in BBs treated with bevacizumab. Intravitreal ranibizumab is shown to cause lesser myopia as compared to bevacizumab. However, we need to weigh this with caution as this data is diverse from various geographic regions, and it is not entirely clear if laser alone is responsible for the myopia. Now, is this refractive error likely to progress? So as we saw, this was a spectrum. So in cases where the myopia is just related to prematurity, it may resolve as the emmetromization may still progress. In cases of spontaneously regressed ROP, it may plateau by 2 years of age and may remain stable. While in cases of laser ablation, we may expect low to high myopia. Does this child need to be given glasses? Yes, definitely this child needs to be given glasses. So to summarize this topic, prematurity, low birth weight, and ROP are risk factors for causation of myopia. Severe ROP predisposes to higher myopia. Intravitreal injections for ROP treatment may be associated with lower myopia. The refractive outcome should not really direct the treatment modality for treating ROP. Refractive error is due to steeper cornea, shallow chambers, thicker and anteriorly placed lens, and not due to axial elongation. So in this cohort, the atropine drops that are used for controlling the myopia progression will not help. And the prediction of the refractive error is imprecise due to a multitude of factors and requires regular follow-ups. So all in all, basically the story of the ROP child does not end after just treating the ROP, and the follow-ups need to continue. Thank you very much.
Thank you, Dr. Prachi, for that interesting talk on myopia and prematurity. Over to our next speaker, our own dynamic, Dr. Siddharth Kesarwani, who is a gold medalist from the Mumbai University, having done his fellowship in LVPI in Pediatric Ophthalm, Strabismus, as well as Neuro-Ophthalm. He has more than 24 of articles and publications in peer-reviewed journals nationally and internationally, and he himself is an editor, sub-editor at the IGO. He is also known for a new technique in capsulorhexis for cataract surgery in capsule having fibrous plaques. Over to you, Dr. Siddharth.
Yeah, good morning, everybody, and thanks for that very generous introduction. I'll jump straight to the topic. Now, it's been a long time since the ATOM was published. I think in 2015, the last reports came, and our current practice patterns as far as atropine therapy for myopia control is concerned is more or less based on those results. But it was an incidental finding in ATOM, if you remember, because 0.01% was supposed to be the control group of ATOM 2. And they found that it had a clinically significant reduction in progression. And that's how they concluded that because it had a clinically significant reduction in progression, it was a good 0.01% atropine was used. And it was not even intended to be one of the treatment arms. So what we think we know so disputed. Absolutely no problem with that. The efficacy is dose dependent, and so is the rebound. Again, there is no dispute regarding that. Low dose atropine retards myopia progression. Yes, it does, but is the effect clinically significant or not is something which study. And the safety profile is proven beyond doubt, because even after giving it for 5 years, there was no.
Siddharth, you're not very audible. Siddharth, you're not really audible.
Pardon?
You're lagging, Siddharth.
Siddharth, you can off your video so that the bandwidth is less used.
can off your video, sir.
Siddharth, you can turn off your video so that
now?
the voice is more clear.
Have we lost Siddharth's? No, he's there.
I think we should take up at the last.
Yeah. So we can take the next speaker.
Can you hear me?
Yeah, Siddharth, are you there? Yeah, can you? No, we can't hear you.
Yeah. I'm sorry. Yeah, I have an unstable connection. I'm sorry.
Okay.
Can you hear me?
Yeah,
Yes. Please go ahead.
Go ahead.
Yeah. So, these unanswered questions were needed to be tested. So what are we not sure about?
We can't see your slides, Siddharth.
Yeah. I think it got disconnected. I'll just share one second. Yeah.
Sure.
Sorry, I'm so sorry. I have a very unstable internet connection. I don't know.
So it's okay now.
Yeah, I think
Yeah.
So
Let's see.
even after ATOM, what were we not sure about? One is how does atropine actually do it? We are not sure about that. When should it be started? When it should be stopped? How to taper it? Whether some delivery system which is better can be used? All these questions were not answered. So that's why another study called the LAMP study was launched, and it has already completed the phase 1 and phase 2 data. What it tried and they used a historical control. So a small amount of criticism was that probably the effect of 0.01% was an enhanced placebo effect and not really a clinical effect. So the LAMP study takes care of that as it has 4 arms. One is 0.05%, one is 0.025%, 0.01%, and the placebo arm. And the results of LAMP study at the end of 2 years show that that 0.05% is much more effective than 0.01%. And as you can see, the effect at the end of 2 years in 0.01% is 1.12 diopters of increase, which is almost twice as much as what was shown in ATOM 2. And believe me, after ATOM 2, no other study has been able to show an effect which is as great as what was seen in ATOM 2. It is always less than what was seen in ATOM 2. Even in our clinical practice, we never see the promised ATOM 2 benefit with 0.01%. It is more or lesser than what we have seen in ATOM 2. And most of the studies, including this one, has shown that the effect was much less. In fact, in this study, they showed that the 0.05% arm was the one which was showing an effect which is equivalent to the 0.01% arm in the ATOM 2 study. So, and they showed that with 0.05% also the side effect profile was more or less same as 0.01%. And that's why they have suggested that probably we should start thinking of using 0.05% as the treatment of choice instead of 0.01%. Another very interesting study was published in January 2020, where author has randomized the treatment group and the placebo group. The treatment group is actually using 1% atropine once a month. And how they are using it is that on suppose the first of the month, they are putting it in the right eye, and 15th of the month, they are putting in the left eye. Then again on the first of next month, they are putting it in the right eye. And then again on the 15th of the next month, they are putting in left eye. Like that, they have put for 2 years. And in the placebo arm, they have put just the saline drops for 2 years. And then they have put it twice monthly for a year, and then they have stopped it. This was to tackle the rebound effect seen with ATOM 1 and ATOM 2 as far as the higher concentration are concerned. ATOM 1 and ATOM 2 both had showed that higher concentrations are much more effective as compared to the lower concentrations. Only problem was the rebound effect. The moment you stop it, the rebound effect is so vast that it immediately comes back to the baseline of almost equivalent to the placebo group. So this author found that if you taper it slowly, then the rebound effect is less, and even after stopping after 1 year, the next year the effect was sustained. So this study was conducted for 4 years. In the first 2 years, it was once monthly, and then in the next year it was once every 2 months, and then it was stopped. They showed a reduction of almost 70% in myopia progression. The advantage of this therapy was that the initial photophobia and difficulties lasted for a couple of days after the installation of the drop, but the person got adapted to it. And because only one eye was being treated every 15 days, they could manage with it. Although there was a 20% dropout in this study, still you can think of reducing the frequency of atropine when we move on to just like in pedic studies, it was shown that weekend atropine is as good as daily atropine. Probably will reach a stage where we'll start prescribing even dilute atropine once in 2 days or once in a week or so. This is another progress that has happened. Now, because all these studies were being done in the Southeast Asian population, we are not sure whether it works equally well in other ethnicities. So all the countries have started their own trials. Ongoing trials are there in USA, India, Britain, China. They're trying to evaluate the efficacy of low-dose atropine in their own population. Yes?
Please continue.
Carry on.
Yeah, one more concept is, should we start using atropine in the pre-myopia phase? The pre-myopia phase is where the refractive error is between plus 0.5 and minus 0.5. Although this study was published in 2010, where they showed that in a high prevalence population, the incidence of myopia was reduced from 54% to 21% after using 0.025% atropine for 1 year. But probably this concept is true for high prevalence countries, just like Korea, Taiwan, Singapore, where almost 85-90% school-going children have myopia. There, probably the prophylactic action of myopia should be considered. Atropine should be considered. Whereas in our country, the incidence and prevalence is much lesser than those countries, although it is increasing. So maybe we have not reached that phase where we'll start doing prophylactic treatment of atropine. However, we can also think of giving it to patients who have very strong preponderance of developing atropine, just like both have parents having high myopia, sibling having high myopia, and a very early onset myopia, history of prematurity, which we just talked about. Probably we can offer at the age of 5-6 years when they are in this pre-myopia stage, we can offer and probably prevent or postpone the onset of myopia. Now, even another drug delivery, the compliance is a very big issue in small children. Now, Dr. Nipa Thakkar says that she doesn't put it in 6-year-olds. In LAMP study, the inclusion criteria was from 5 to 15 years, and there are studies which have gone up to 3 years. So it has been shown safe in younger children, although I don't personally recommend it in less than 4 years of age. Because recently there was a publication in IOVS which said that if you put it in less than 4 years, the natural hematropization process is hampered, and you have to give the chance to develop on its own. And so that's why I limit it for anybody who is over 5 years, because that's the current evidence. The other delivery systems which are being tried right now, but the data is not yet out, are microdosing atomizer. They create like a mist cloud in front of the eye, and that's why that entire horror of putting eye drops in small children is avoided. Second, because it is a long-term treatment, preservative-free treatment is also being tried. Contact lens delivery was tried in vitro model, but it did not work very well, although research is going on. If you can combine contact lens with sustained release atropine, that would be the best option, because you are giving both treatment and myopia control at the same time. Another issue which
please wrap up, Dr. Siddharth.
Yeah, let's start last 2 slides. One issue is that because atropine is being talked about so much, most of the people think that it works in everybody. But if you go through the studies in great detail, a large number of people do not respond to these treatments. In fact, if you look at ATOM2 and LAMP studies, almost 25 to 30% of patients keep increasing beyond 1 year by 1 diopter or more. So always warn the patient that he may not respond to treatment, and we also should be not expecting the treatment to work in each and every case. The few factors which affect the response are the baseline myopia, the age of onset, and the parental history. So in such patients, we can think of giving them combination therapy with ortho K lenses or with myocyte lenses or with DIMS kind of lenses. Again, I am not going to go into the details of optical therapy, but combination of optical therapy and pharmacological therapy is likely to be additive because both work on different pathways. Finally, I
Siddharth, you
just
have to
brushed
summarize, please.
just last slide. I just brushed through the GPOS guidelines because Himalini had told me that I have to talk about this. GPOS guidelines in 2018, these are the following recommendations, which we may have to change very soon based on current evidence. You start it if the progression is more than 0.5 per year. Start it between ages 4 to 5 to 50, for 14 years of age. Continue for 2 years or till the age of 16 years, whichever is early. Once nightly dose is given, first follow-up is at 3 months and then 6 monthly. Measure the axial length and cycloplegic refraction at baseline, and then in subsequent visits only measure the cycloplegic refraction. Continue at least 1 year before you say he is responding or not responding, because the effect is slow to start. In fact, in the first 6 months, uncomfortable. The child is complaining of any photo.
Siddharth, I'm really sorry, but you will have to wind up now.
Or decreased vision. Use progressive glasses. But okay, I'll wrap up. That's my live slide. So thank you so much.
Thank you, Dr. Siddharth, for excellent information. Now, I would like to invite our next speaker, Dr. Sumita Agarkar ma'am, on the topic when not to use low-dose atropine. Dr. Sumita ma'am.
Can you stop sharing your screen?
Yeah. Dr. Sumita Agarkar is prominent pediatric national faculty. She is consultant in Shankar Netralaya since 1999 and currently deputy director in
Sorry to interrupt. Siddharth, please stop sharing your screen. Siddharth.
The numerotech technical guys, please stop screen share.
Yeah, it's done. Dr. Shirish, please continue.
Yeah. I would like to invite Dr. Sumita Agarkar ma'am, a prominent national faculty, currently deputy director at SN since 1999. And she has got more than 50 publications to her name. Over to you, Sumita madam, for your talk.
Thank you to Bombay Ophthalmic Association for inviting me. BOA is like a second home. And I'm going to be devil's advocate here in this myopia session to see where low-dose atropine may not be a good idea. Now, intervention for myopia, I think several speakers have suggested why we should intervene, and these are one of the compelling reasons why we should probably look at myopia intervention. And if you look at India, and these are the from India itself, there has been a massive increase from 3 to 6% to nearly 12 to 15%. And in Shankar Netralaya school study data, we found almost 18% in Indian urban children. Especially if you go to private schools, it increases to more than 25. So it is probably something which we need to look at interventions. And again, several speakers have alluded to this, but there is really no safe myopia. If you can see, myopia does increase risks of cataract, retinal detachment, maculopathy in almost any amount of myopia which a child may have. So what are your strategies which are effective in the sense which has been proven effective with randomized control studies? So we have atropine drops in various concentrations. We have orthokeratology, which definitely has proven retardation of progression. And a latest study which has come out is with DIMS or diffuse incorporated multiple segments, which also showed definitely reduced progression. So these are the things which we know about atropine. Has been proved in several studies all over the world, different ratio ethnic populations, several prospective studies, and at least there are 3 Indian studies which are available for review, well-designed trials, all published, including one Shankar Netralaya study which came out last month in IGO. So there is enough evidence that it does work. What we don't know is how it acts. And we definitely have a lack of consensus on non-responders. And we really don't know the long-term effects of this in a very, very younger children, which we regularly use. So when I looked at the literature search for this, again, there are no clear guidelines. I could not find a single literature where I could find where it clearly specifies where it should not be. So this is my personal list. And I have several panelists who are top of job in there. So I would request all of them to add to this list if there is any. So one is no-brainer, allergy to atropine. Probably you should not use if the child is allergic. Then non-responders, anterior segment anomalies. Again, let's look at it one by one here. And if you have atropine-related adverse effects, which can start from simple pharmacological effects like dryness of mouth, flushing, tachycardia, restlessness. Again, this has very rarely been reported with low dose atropine, but with higher doses of atropine, these has been reported, and that's one of the reasons why compliance has been less with 1%, though it is most effective for myopia control. None of the prospective studies with low dose atropine have reported any serious side effects, including our experience in Netralaya. Children on antimuscarinic medications like some antihistaminics or some antidepressants can have additive effect with topical medication, and you should probably talk to their physicians before starting medication for myopia control. Again, Down syndrome children also are likely to have exaggerated mydriatic and cycloplegic response, and caution must be exercised. Same for asthmatic children. And these children, you probably need to discuss their systemic conditions with the parents and their other primary caregivers. And also important to explain to the parents the correct way of administering the drops to minimize the accidental overdose. This is especially true in our country where the summers and can be very hot, and if the drop is left outside, it can evaporate and concentration may become more than 0.01% what you intended to be. So correct application should be definitely be demonstrated to the parents, especially if you're starting in very young children. Now, non-responders is another category where you should probably not use atropine. Again, how do you define non-responders? Probably who continue to progress more than 0.5 diopter despite good compliance and even after using 2 years of using drops. So there is no point in continuing just because it is safe for use up to 5 years. You need not continue atropine in these children who continue to progress. At least 1 year before saying non-responders, but ATOM study has proved that sometimes children who don't respond in the first year often responds better in the second year. So I think 2 years should be your cutoff before dubbing a patient as non-responder. Again, percentage of non-responders can be around 16 to 18 and some patients have improved. So these are the patients where you probably need to look at other options, optical options or other options to reduce the myopia progression. Again, both the strategies of increasing frequency or increasing the strength seem to be reasonable, but there is no evidence as which works better at this point of time. Ocular comorbidities like subluxated lenses, microspherophakia, keratoconus, juvenile glaucoma, we have seen all of them with atropine in my practice, being prescribed with atropine, missing out the primary condition responsible for myopia. And a careful examination should always be a part of your workup before you starting myopia treatment in these children. And obviously, these are not the right candidates for low-dose atropine because the problem of myopia is not axial and something else. Syndromic or very high myopia or pathological myopia. Again, several syndromes like Marfan's, retinal dystrophies, Stickler, FEVR can present with high myopia without any obvious pathology unless you see a very good dilated examination, and sometimes can be missed. But these children are often non-progressive and role of atropine is not clear in these conditions. These conditions have never been included in any of the studies which have been published and were almost always an exclusion criteria from most studies. These children often present with high myopia at a very young age, and I would definitely wait for more evidence before considering atropine in these children.
Ma'am, 1 minute left.
Younger children and pre-myopes. Now, ATOM-3 is a prospective study which is looking at the effect of atropine in this group. However, there is no evidence as yet whether atropine can prevent myopia in this group, which has been published. So jury is still out, and we really definitely need to look at this group because these children are likely to progress more and more likely to be non-responders to low-dose atropine, as has been reported in lab study. So, but jury is still out on these children. Thank you for your attention.
Thank you, SAR ma'am, for that brief and crisp talk. Our next speaker is the head of JVR Children Eye Care Hospital, LV Prasad, Hyderabad. He is the shining light of Indian Pediatric Ophthalmology, being the Executive Bureau Director of WSPOS. He is a receiver of a number of awards, including the prestigious Achievement Award at the American Academy of Ophthalmology, a passionate researcher and an enthusiastic teacher. I would like to welcome Dr. Ramesh Kaitanya. Dr. Ramesh, please take over.
Thank you, Dr. Shalini, for that generous introduction. I would like to thank Hemalini and BOA team for this invitation and having me here. It's so nice to see all the colleagues nowadays with online webinars. I'll be talking on something different. We finished with pharmacology. We will go on MBBS with tips in cases of myopia. Why it is different, we need to understand that there are three different things which will happen when the patient has myopia as well as strabismus. It does lead to optical effect, probably because of opticals, especially with the glasses. It can lead to a prismatic effect. That will strabismus surgery is nothing about measurement. Your measurement can be over measured or under measured in cases of myopia or hypermetropia. That's why refractive error plays an important role. That's the first effect. Second thing is it can have an effect on the accommodation. Already some of these things are discussed in this previous talks, but there could be a difference in the near and distant disparity, specifically because of accommodation. And the third one, which most of us are very, very well versed with this, the globe size, which leads to mechanical displacement of the extraocular muscles. And sometimes the space occupied in that orbit, the eyeball size could be really, really big. It cannot even accommodate that. These are the three effects. If you look at the classification or types of strabismus in myopia, these are the broad categories: concomitant primary, concomitant secondary, incomitant, and some are others, like progressive esotropia can happen in low and moderate myopes. And all of us see the concomitant primary, either esotropia or exotropia with myopia. Concomitant secondary, I think Dr. Prachi covered a little bit of it. The ROP and prematurity related, they will have high myopia. They're also prone to strabismus. And obviously, if one of their eyes goes into phthisis or a retinal detachment or burnt out ROP, they can have a sensory strabismus. That's a very, very low amount, I would say. But all of us are very conversant with the incomitant strabismus, specifically esotropia hypertropia complex and exotropia hypertropia complex. Whatever is highlighted in yellow, I will try to cover case example for the same. One thing you need to remember is minus measures more. Look at this picture on the upper panel with the glasses, without the glasses. See that what is the optical effect of this as well as accommodative effect. With the glasses, you can see in her upper panel patient, the esotropia is much more. Look at the next picture, that's the middle one. She has a very high myopia there in the right eye with the exotropia. And the last picture lower down, you can see how this acts as a concave glasses, acts as a base out prisms. That's why simple thing to remember is minus measures more. What we do at this kind of situation is you can see the similar thing with the contact lens. On the left, she is wearing glasses. On the right, she is wearing contact lenses. Because of wearing these contact lenses, you can see a significant difference in their amount of strabismus. So I would say tip number one is just look at the optical effect and prismatic effect. If possible, if feasible, try to nullify this by giving a contact lens prescription for the same. And in spite of contact lens that does not come down, then go on to surgical or other methods. And in a comitant esotropia or exotropia, if you have, what is the amount to be corrected. You can see the measured tropia, 5, 10, 15. And you can see the on the x-axis, the amount of deviation, what you can expect with the different amounts of myopia. The easy way I remember is -5, -10, and -20. This is the most common, I would say, between -5, -3 to -10 is the most common patients you will encounter. This is what is one of the example. You can see a very large myopia, the strabismus here, close to 40 or 50 prism diopters, but her glasses power is 4.25. So as a simple rule of thumb, I would say if there is up to 5 diopters of myopia, you can undercorrect 10%. If it is more than -10, it's 20% correction. If it is more than 20, that is 33%. You can use this rule of thumb, or you can use this table in concomitant deviations. When it comes to incomitant, there is a, as I said before, there is an exotropia hypertropia complex, as you can see here in this patient, huge exotropia with hypertropia. Incomitancy, whenever you see imaging modalities, must specifically quasi-coronal cuts at the optic nerve globe junction, which can tell you whether there is any nasalization. In this patient, there was nothing. So we went ahead with the routine surgery of resect with upshift of the horizontal muscles. And we also had to do a superior oblique because there was a large hypertropia. And this is the post-op picture for the same. And in summary, exotropia hypertropia can occur with high myopia, but there is no specific etiological factors or clinical or radiological factors which are identified in this cohort. And the successful alignment can be used in these cases with the tailor-made approach. As you can see here, exotropia hypertropia, this is managed by a loop myopexy of medial rectus and superior rectus. So you have to decide this decision of surgery based on case-based. And this is one of the publication by Dr. Sandra. She has published on this nasal loop myopexy as a pure primary procedure for the same. So this is where a suture myopexy has been used between superior rectus and the medial rectus. When you have esotropia hypertropia, the problem is not the same. The problem is with the superior rectus and lateral rectus. In exohypo, there is medial rectus and superior rectus. You can see in the second picture on the right, significant displacement of the superior rectus and lateral rectus, where we have to correct this mechanical problem either by silicone band, as you used in this picture. You can use even loop. There are different graded approaches we have to go depending upon the deviation in these patients. And this is an immediate post-op picture of these patients. They improve significantly both in terms of deviation, as you can see here, and also abduction that significantly improves. As you can see in one more patient here, it's one of the most gratifying surgery, the Yokohama procedure. He has done a wonderful, he's the pioneer of this procedure. It's one of the gratifying surgical procedure in strabismus. In summary, I would say whenever you come across with a patient of myopia and strabismus, look at the amount of myopia, look at its effect, whether it is optical or is it mechanical, or is it the effect is on the accommodation. Obviously, see for concomitancy and incommitancy. Then you can begin with optical correction or non-surgical management in terms of contact lens or prisms if the deviation is very small. If you have to do surgery, then surgical dosage depends upon the undercorrection, what I mentioned, up to 5 diopters, 10%, more than 10 diopters, 20%, more than 20 diopters of myopia, 33% undercorrection. Imaging, you need to utilize this technique in most of the patient and then decide about appropriate surgical options. Thank you so much for this opportunity. I would be happy to take any questions at the end if there is time. Thank you so much for having me today.
Thank you, sir, for this interesting and informative talk. The next speaker today is, she's a best speaker and the last speaker, Dr. Meenakshi Swaminathan, madam, who is a senior consultant since more than 20 years, associated with Shankar Nethralaya. Madam is trained in US and she is very passionate about teaching and research. She is also invited faculty in multiple international and national conferences. And I should also add that she is a very popular teacher. Madam is also an avid singer. So over to you, madam, for your talk on pediatric ophthalmology in relation to the pandemic.
Thank you so much, Dr. Naina and esteemed panel. So I just thought I'll wrap up this session with a very different talk. A collective, do we deserve a pat on the back for how the year was, the year of the pandemic? How did we do as a specialty, pediatric ophthalmology? How did we do as pediatric ophthalmologists? So that's what my talk is about. So I have no financial conflict of interest, and the data I've collected from is our WhatsApp Kids group from Google, YouTube, Facebook, Instagram, discussions with my colleagues, and memory. And if I left anybody out, it is purely ignorance. How did we do in patient care? Well, when the pandemic started and we all went into lockdown, we seemed to have to resort to teleconsultation. So there was an excellent editorial, a guest editorial by Dr. Pradeep Sharma in the Indian Journal of Ophthalmology, which with the title of Distancing, but Still Eye Care at Ophthalmology during COVID-19 era, which gave a lot of excellent suggestions on what to do and what not to do, which was a good start for us who were people who were resorting to teleconsultation. Soon, this was followed by this paper from Ramesh's group from LVP, which looked at teleconsultation with initial experience of 198 patients, where they felt it was an excellent idea, that the experience was very encouraging. Of course, we don't have, this paper did not talk about the feedback from the patients, but we know over the year the feedback from patients has been positive as well. So how about guidelines? We needed guidelines. So there were global guidelines, which came from APOS, which are still available, and how to do vision screening. And the All India Ophthalmological Society also came up with excellent guidelines that were more India-centric. And we had a working group and a writing group that published this in the IJO. There were more ideas that came out of this pandemic. For instance, in Shankar Nethralaya, we partnered with Titan Eye Plus, where to 230 odd cities, we had where Titan Eye Plus centers were present. Our patients who could not travel to Chennai could go get their eye tested. Our EMR was accessible from the Titan Eye Plus store, and thereby we could immediately follow this up with a teleconsultation with the actual eye test having been done at a recognized eye place. Titan Eye Plus opticians are trained at Shankar Nethralaya Academy, so we are ensured of a certain care. So some of our pediatric ophthalmologists went the extra mile. This was Dr. Shruti Nishant from the MNI Hospital, Chennai, who actually delivered low-dose atropine drops to patients who could not visit the center due to the pandemic and the lockdowns. We had other ideas for creativity, where we just launched in Shankar Nethralaya this channel called Punar Netra. This is to bring the special children who need vision rehabilitation into the fray. So this is a YouTube channel which is accessible to all, which has got excellent videos of how to do exercises at home for the parents. It is called Punar Netra. Also, there are excellent apps available for patient care, for one called Eye Handbook and another which has a bunch of eye test charts. And this one we're all very familiar with, the 9Gaze app, which we share liberally photos. This brat, thanks to the app, I was able to diagnose the superior oblique overaction in the A pattern and why he had a chin down posture. Okay, Now, we're going to move on to continuing education, of which we had a lot. Did our residents suffer during the pandemic? Yes. There were editorials, there were surveys that were published in IGO that supported what we already knew, that ophthalmology training programs were impacted by the COVID-19. But the All India Ophthalmology Society, again, kudos to them, came up with excellent PG updates and pediatric ophthalmology was not left out of this. All the recordings are available on Facebook for the use of our residents. We in Shankar Netralaya used the Google Classroom to create content and create evaluations on various topics, especially targeted to residents. What about fellows? Our fellows who were seeing less and less patients because of the lockdowns and the less patient flow were encouraged through this Google Docs, which continues even after a year, where they would post a case and everybody would get to weigh in on it, and faculty were encouraged to comment about the case. Everybody, every hospital pitched in, every institute pitched in with excellent webinars and CME programs. Every state society had excellent programs which covered pediatric ophthalmology. CyberSight had some wonderful webinars, but the mother of all, the virtual conferences, both WOC, SPOCI, they all went virtual. But the icing on the cake or the crown or the Oscar goes to the WSPOS worldwide webinars, which Ramesh has been an integral part of. And they continue till today, week after week, giving us some excellent educational content. They're all available as well to access. And of course, we went through a very unique 24-hour continuous worldwide connect, which is still fresh in our memory. But Ramesh, I really should congratulate you on this very recent initiative where you took the bedside examination of patients to all. My residents enjoyed this immensely. What about media and advocacy? How did we do as pediatric ophthalmologists? How did the media do? Did they cover us? Yes, progression of myopia in school-age children after the home COVID-19 confinement was reported in JAMA, but it was also covered by the AAP News. AAO had a segment on it. We also had Times of India, Hindustan Times, and the Washington Post all cover about how increasing screen time was affecting our children. There was a rise in myopia. But this is one of my most favorite articles, which is in a journal called The Conversation, with academic rigor and journalistic flair, which goes into details about how the pandemic and the increased screen time is affecting our children's eyes. Of course, Dr. Vashini Shankar was one of the first one to come up with a PDF talking about screen time. She went on to talk about it on Facebook. Dr. Shruti Nishant, 5 simple effective tips for online classes on Instagram. And we had our own Dr. Jitendra Jethani, who had really excellent videos, even including the recent one on screens and children, how much is too much. These are all available for the public on YouTube. And of course, many of pediatric ophthalmologists also demonstrated some hidden and not so hidden talents. There is Dr. Atul Sheth, and there is Dr. Aloka, and yours truly as well. We all took part in the Sangeet Setu. But I like to conclude with this cute little poem that or verse that I found on our kids group as I scrolled the last 1 year content, which says, "Thoda clear hai, thoda samjhana baki hai," and it ends saying, "Kafi kuch clear nahi hai, lekin kafi kuch samajh chuke hai." How succinct and how beautiful. So I think pediatric ophthalmologists, we need to give ourselves a pat on our back. We didn't do too badly in the last 1 year. We actually did quite well. Thank you, BOA and Himalini, for this kind invitation.
Thank you so much, ma'am, for that really fantastic presentation. Now let's move on to some questions and some discussion.
Shalini, you have 10 minutes, all right, for questions.
Yeah, yes, we do. So we can take that extra time? Otherwise,
yes, you can. 10 minutes.
All right. All right. So Siddharth, I wanted to ask you, like with the atropine, is the whole panel, are we using atropine for adults like more than 18 who want to say go for LASIK, but the number has not stabilized? Are we using low dose atropine for that?
No.
Ma'am, SAR ma'am, you. Yeah, okay, Siddharth, you're there, right.
Yeah, so recently there is a trend of late onset myopia. A lot of children start getting myopia after the age of 16 years. So in those cases, yes, I do advise them atropine for some time to stabilize.
All right. Also, I think there have been isolated cases where low-dose atropine has also been used in patients having accommodative spasms. Do we do that routinely?
I have not used it in any such case.
I don't think it relieves the spasm. I had one patient who was using it absolutely instead of the 1%. The spasm was just not relieved. So
I don't think it would be as effective.
So going on, sorry to interrupt you, Shalini, going on with accommodative spasm, does everybody start with atropine first, or do people start with homide first and then progress to atropine?
Atropine.
Okay. And how long?
At least a month.
Okay.
And I have some audience questions that I wanted to ask because I'm signed into the audience segment as well. So this question is to Dr. Sumita. The question's from Dr. Jagdisha. He asks, your data of myopia prevalence is pan-India based or SN hospital mainly of South India?
What I was saying, 18% is from our school screening data in and around Chennai, mostly Chennai schools.
Okay. There's a question to anybody in the panel. That is the youngest age to start prophylactic atropine. I know Siddharth touched upon it, still a controversial area. Does anybody want to weigh in on it?
See, if you are going to use prophylactic already, it should not be used less than 5 years of age, because till 4.5 your normal hematropization is going on. And since somebody can get transient myopia and grow out of it also. It's not that only hyperopia resolves. Even at the age of 2 years, if somebody is getting myopia, hematropization can take care of that also. So don't assume that somebody who's got 2.5 years, he's got -2 is going to increase. No, that doesn't happen, because the lens is also changing, the cornea is also changing. And the atropine doesn't have any effect on lens and cornea, it only has effects on the sclera. So when you want to use it prophylactic, you want to be sure that you are going to use it as a prophylactic treatment for school myopia or simple myopia only, and not any other kind of myopia.
Okay, so there's also a question from the audience. Can atropine therapy, is it necessary to be started by a pediatric ophthalm, or can a general ophthalmologist start?
Sumita ma'am, please answer.
We are very few in number. We are all concentrated in cities. So no children should be denied this option. So I would not keep it. Only request from all the general ophthalmologists is do a proper exam. As I said, I have seen each of them: juvenile glaucoma, keratoconus, high astigmatism, glasses and prescription and atropine prescription at the same time. So I think a proper pediatric examination is required, a proper documentation of progression is required, and I think anybody can start. I think we should not deny children who are living in small towns or who are even tier 2 cities should not be denied this just because there is no hard and fast rule. Only thing is there should be a proper pediatric eye examination, comprehensive eye examination, and there should be a documented progression to start atropine.
There is also a question for orthokeratology. There is a question to Dr. Yasmin. It says, who supplies orthokeratology? What are the tips for fitting? And can you combine atropine and ortho-K?
I think she's answered that in the chat box, ma'am.
Okay. She's not here to answer. Okay.
Can you just give that answer out?
Yeah, can you read it out?
Okay. Dr. Yasmin is not there. 1 second. She's written that to order ortho-K lenses, please get in touch with me to discuss additional details. Same applies for fitting. And yes, it can be combined with the atropine.
Anybody who doesn't have a number can contact me and then I'll pass on the number.
Also,
Can
any
I-
more light on the MeSoft and the bifocal contact lenses? Siddharth, maybe you were talking about DIMS and all. Just, are we using it frequently? Is it being prescribed in our practices?
Yeah, it's not available in India. Myosight lens is available in USA and it is FDA approved. DIMS lenses are still under evaluation. They are not yet FDA approved. Although Hoya has already made DIMS lenses, so it's available as a product, but it's not FDA approved. It is used in Malaysia. So DIMS lenses are being used and it's marketed by Hoya lenses and they are available in Malaysia.
Yeah,
Myosight lenses are
Singapore as well, I think.
Yeah,
probably. And
they are in
in
talks with us, and most probably Hoya is going to launch in India within 2-3
Right,
months. Is what they are
right.
saying.
And Myosight lenses are there available in USA from Cooper Vision. Last I checked, not available in India. I hope they launch it to us.
Sumita ma'am, may I ask you a question? Can we add,
Ma'am, yeah.
should we add pseudophakic myopic progression to your list or keep it out?
It is a bit controversial. If you look purely evidence-based medicine, there is nothing. But evidence can be generated only when you do it, right? You can't do evidence generation without trying it out. So I think there can be an open trial because it's a FDA-approved safe drug. Again, confounders there is going to be glaucoma, most important. So do not start unless you have intraocular pressure checks. If you don't have IOP checkup, don't start. But otherwise, I think there is a little bit of, I think Mihir had presented his data and both Jitendra has also presented data, and from their data, it looks like it is effective and working for those children also, but nothing in the published literature as such as yet. But no harm in starting and no harm in evidence can be generated only if you try it.
Yes, that's right. Last question for anybody on the panel is, what do you do to non-responders? Whatever your definition for non-responders are, 1 year, 2 years, 0.5, 0.75 per year, do most of y'all go the pharmacological way, or do you add a non-pharmacological, which means increase the frequency of 0.01% or increase the percentage, or do you go the other way? I know most of us don't have any clear evidence, but what is your first thought? Do you just still go the pharmacological way, add a non-pharmacological method? Any?
I think if it's a younger child, say 6 or 7, who is progressing, probably it makes sense to increase the percentage. Although there are no commercial preparations available for higher percentage, we have either 0.01 or 1, nothing in between. And compounding pharmacies, none of us have access. Cooking up the drops ourselves, again, makes patient has to come each time. Stability and everything is a problem. So I actually have been requesting pharma companies to come up with 0.2.
Correct.
And so younger children, probably increasing the percentage will be more effective. But this is my personal thought.
Yeah.
And probably in older children, you can look at increasing the frequency and see.
So would 0.2 be an option, or as per the LAMP 0.05%, would that be a better option? If we have to request pharma companies, say, for the next one?
I would suggest 0.02 rather than, because that could be your starting drop. Ideally, everything should be available.
But in all places where everything's available, it's usually they are cooking it.
They're cooking it.
Because it's it is not economically viable for the farmer.
It's not viable in Singapore. It is viable in India, man.
Yeah, right now the pharma companies are focused elsewhere. So anyway.
I have one question for Ramesh sir actually. So for squint and myopia, so you talked about putting contact lenses and measuring, and we get a difference when we measure with the glasses and the contact lenses. So does the measurement have to be dependent on what the patient is going to use after surgery? I mean, there are some patients who really don't want to use the contact lenses after surgery. So does that really affect the way you look at it?
Yeah, even if they want to do to continue the contact lenses or not, Prachi, I would still measure it because I can average my surgery. If there is a difference between, otherwise I will land up in significant overcorrection or significant undercorrection. We all know that contact lens makes a difference of 5%. Contact lens can make a difference of 30 to 35%. We know. I can't say for sure that, okay, this patient will have 10% difference unless I try. At least for that reason, I will do. And if I see a 30 or 35% difference between the pre and the post contact lens, I will caution the patient. It looks like ideal situation for you is either go ahead with the LASIK or contact lens and then come for it. Otherwise, be prepared for undercorrection. These are the additional things we can do. However, whatever said, there are subgroup of patients who will not use contact lens. Whoever used to use glasses for 18 or 19 years, they will not suddenly jump. I agree that's a practical problem we all face. So I would use this knowledge as a dosage and probably counsel the patient that way. But having said that, that overcorrection, 30%, 40%, I'm saying, they are on the minority.
Dr. Ramesh, question. Like you said, imaging. Myopic strabismus fixes, we obviously will image. But is there any other criteria for higher myopes in 9-10 who don't have such large deviations and just have probably an exo with a small hyper? Do you think we should image them also? Do you expect any anatomical variation in these patients?
I would correlate the axial length, Dr. Shalini, to really ask for or not. You know, many of the concomitant strabismus without any vertical component, I won't. But otherwise, it is important because I have a patient. I thought it's a myopic strabismus fixus. Actually, it's a neurofibromatosis caused by some deficiency of sphenoid wing, causing this exo and hypertropia. I'm bringing up the rarest form, but even that rarest thing, we don't want to miss one. One patient had a lamina papyraceae fracture, which was exactly simulating like a myopic strabismus fixus. I would say there are 100% I would do imaging if there is incompetence and vertical component. Otherwise, I might get away without doing an imaging. And if it is so difficult to get an MRI, I would at least get a quasi-coronal CT scan, which is around 1,500 rupees. Most of the patients can afford. If economics is a real problem, I'm okay with that as well.
I think we have the next team already lined up. Dr. Hema, should we?
Yeah, I think Shalini will call it a day.
Yeah. Thank you so much, everybody. We had a great discussion. We had lovely presentations. Thank you, and looking forward to seeing you next year as well. Thank you.